Hi everyone. So for session 4, we're going to go over a surgical emergency case-based discussion. Hopefully this session will bring together everything that we've learned from session 1 to 3 to evaluate an unwell surgical patient. I think this session is really helpful to practice presenting case-based discussions. This is something that you might be doing in a final year OSCE, something that you might do in a core surgical training interview, or just in a grand round presentation whilst you're a foundation doctor. So the case that we've got here is that you're an F1 in general surgery. You've been asked to pre-operatively assess a 72-year-old man for a right hemicolectomy for a carcinoma. All that you've been told about him is that he has a history of AF. So imagine the situation in which you're in A&E, you're in the surgical take team, and your registrar says, this man's come in, the CT report has shown that he has a carcinoma. Maybe the patient's got symptoms in which they need an urgent surgery, and you've been told to go and do a pre-operative assessment of the patient. So what information is really important for you to get from that history when you're first approaching the patient? So we've been told that the patient has atrial fibrillation, and we want to think about any symptoms that might suggest poor rate control or any underlying heart conditions that would need investigational treatment before surgery. So specifically asking the patient for any exertional chest pain. So if, when they run or when they walk quickly, they have any pain in their chest, any shortness of breath, any syncope, any palpitations. We also want to know any AF specific medications for the patient. So are they anticoagulated? Do they need any rate control? Are they on beta blockers, digoxin, any calcium channel blockers? Potentially calculating their CHA2DS2-VASc score, seeing if they've got any previous TIAs, strokes or VTEs. Rate control is usually continued in the perioperative period, and that's especially with regards to beta blockers because they can decrease the risk of perioperative MIs. So we also want to elicit whether the patient's got any other medical problems relevant to surgery. So are they diabetic? If they're on insulin, how are we going to manage their sugar control around surgery? For example, if the patient's nil by mouth, you want to put them on a variable rate insulin infusion or a sliding scale preoperatively. Does the patient have a history of ischemic heart disease or angina? Is there something that we can do to optimise it before proceeding to surgery, such as an angio? And do they have an increase of a perioperative MI? Does the patient have COPD and asthma? If so, they'd have an increased risk of pneumonia or a COPD exacerbation or an asthma exacerbation post-operatively. Does the patient have CKD? Are there any medications that we, would want to consider differently in this patient? Other medications that are important are antiplatelets, insulin, long-term steroids, and diuretics. If the patient's on steroids, are there any sickness day rules in which we need to double the steroids? Could the steroids have an effect on wound healing? We also want to ask the patient if they've had any previous GA or if they've had any anaesthetic side effects. With regards to their nutrition, we want to think about how we're going to feed this patient. Are they going to have any enteral feeding? What is their BMI? Do we need to get the nutritionists involved to come up with a good nutrition plan for this patient? Does the patient smoke? What is their exercise tolerance? What is their frailty score, their activities of daily living, their cognition? At the hospital that I worked in, we had a very useful geriatric surgical liaison doctor, so a consultant geriatrician who would help assess the functional status of patients and help to inform the surgical management plan for these patients both pre and post-operatively. So with this patient, we've got to consider what preoperative tests we might want to consider and also say why. So with any patient coming into A&E or going for surgery, we want to do an ECG. If they're brady or tachycardic, do they need any rate control? Do they have any signs of left ventricular hypertrophy, any heart block, or any signs of a previous MI? We want to do an AMTS to see if they have any underlying cognitive impairment, and that's going to affect whether we use a consent form 1 or a consent form 4. Does the patient need an echo? If they have an reduced ejection fraction, that could lead to an increased mortality or morbidity. And do they have any valvular pathology, such as aortic stenosis? A lung function test could be useful if they have any underlying respiratory disease, such as the COPD or asthma that we mentioned. And we also want to consider a chest x-ray. So do they have any signs of heart failure or fibrosis? They might have had a CT chest if they've previously had cancer staging, such as the case of this patient. So it might be useful to go back into their notes and look at that CT and see if there's any pertinent findings there. You want to consider an angiogram if the patient has any symptoms of angina, and potentially they might need stenting prior to surgery to reduce the risk of an MI. And so what bloods does a patient need? In an OSCE situation, you really want to justify which bloods the patient is needing rather than just rattling off a list. So your full blood count would have your HB, hematinics, MCV, and you really want to optimise their haemoglobin level pre-operatively. So if their haemoglobin is below a target of 70 or 80 in the case of heart disease, are you going to want to transfuse the patient? You want to look at their U's and E's for any issues with drug metabolism or their renal function. And you want to consider holding any ACE inhibitors or diuretics preoperatively. Looking at their clotting and INR if they're anticoagulated, or just in any case really to see if you're going to have any clotting problems around the perioperative period. You want to look at their liver function tests for drug metabolism, perform a group and save, and also BNP if there's any concern about heart failure. This might be something that you elicit from the chest x-ray or from the patient's history as well. So given all of the information that we've collected now, you can generate a P-POSSUM score, and this helps to calculate the mortality and morbidity associated with a patient going into surgery, and it can really help with operative planning. If this patient was taking warfarin, what would you as the F1 do to manage this? So in the case of emergency surgery, warfarin can be immediately reversed with vitamin K and prothrombin complex C. With regards to a NOAC, so for example, if the patient was taking a NOAC instead of warfarin, you'd want to discuss with haematology about reversal. You might consider vitamin K, or there could also be a direct reversal agent, which would be more appropriate. I think haematology would be the best person to contact in this instance, so sending a referral over to them. With planned surgery, it's always important to follow local protocols. So with warfarin, that's usually stopped around 5 days before the surgery, and then you check the INR preoperatively. NOACs have a shorter half-life, so they can usually be stopped 24 to 72 hours before surgery, depending on the bleeding risk of the operation. There might be bridging with treatment dose dalteparin or heparin. So for example, if the patient has a very high clotting risk, they might need to have bridging with one of these, with dalteparin or heparin, once you stop their NOAC or their warfarin, but that really does depend on the clotting risk versus the bleeding risk. If the patient has had a recent PE, a DVT, repeated VTEs, they have a metallic heart valve, or they have a very high CHA2DS2-VASc score, they're more likely to need this preoperative bridging. But this decision should be made alongside anaesthetics as well as the surgical team. The decision when to resume anticoagulation post-operatively depends on the bleeding and the clotting risk, and that will usually be something that's written in the post-operative notes. So for example, if you were the F1 on call in the evening, you'd usually be looking after the patients who have been operated on during the day. So it's really important to check the notes for the people who have gone into surgery that day to see who needs their anticoagulation restarted. So on the evening after his operation, you're called to see this man because he's cold, sweaty, he's complaining of chest pain, and his pulse is 135, BP 85/60, and his oxygen saturation is 91% on room air. What would you do? So with this, I really want to draw your attention back to our first session, which was an A to E assessment of a patient, and our second session, which was looking at unwell surgical patients, because this will provide a really good framework as to how you should manage an unwell surgical patient. So when managing a patient like this, the first thing that you want to say is that you're aware that this is a critically unwell patient with signs of shock and respiratory failure, and they need an early escalation for senior help. Their new score of this patient will be well above 7. Your differential immediately should be PE and MI, any intra-abdominal bleeding, an anastomotic leak and sepsis, and you want to perform an A to E assessment. So what we're going to do for the next couple of slides is just go back to the very first session and go over the A to E structure, just so it's fresh in our minds before we're able to approach it into this clinical scenario. So going through A, there's more information than you'd probably need here when assessing a patient in an OSCE situation. But the first way that you'd go about it is say, if the patient is able to speak to you, the airway is patent, and then you can move on. But if there are potentially any issues in airway, you'd want to go into a bit more detail. So for the assessment portion, you'd use the look, listen and feel. So you look to see if there's any physical obstruction of the airway, any tongue or lip swelling, any foreign bodies. You could listen for breath sounds, any stridor, any wheeze, any gurgling, any feel for breath. You want to treat things if you see that there's an issue. For example, if there's a foreign body, you can remove it using McGill's forceps. You want to suction, but only suction as far as you can see. If you notice any airway compromise, you want to call 222. You realistically need an anaesthetist there to help you. But you can do some airway manoeuvres in the meanwhile. For example, head tilt, chin lift, or a jaw thrust. And you can also trial some airway adjuncts as well, such as an oropharyngeal or a nasal pharyngeal airway. Realistically, if you're getting to the point where you're doing airway manoeuvres or trying airway adjuncts, you really, really need senior help. But in this situation, a differential could be anaphylaxis, having any blood, vomit or secretions in the airway, or also a decreased GCS. So for situations such as overdose, sepsis, arrhythmias, they're all listed there on the differential side. But let's say if the patient is able to speak to you, you know that the airway is patent, and then you can move on. So now looking at B for breathing, we want to then use our look, listen and feel again. So you can look to see if the patient's in any respiratory distress, if they've got cyanosis, if they're using any accessory muscles, or if they've got chest deformity, if they're coughing. You can listen, so you auscultate at a minimum of 4 points, and you want to percuss the chest as well. And you also want to see if there's any tracheal deviation, any decrease in chest expansion, looking at their JVP. And importantly here, you want to look at the observations, the respiratory rate, the oxygen saturations, and if indicated, do a chest x-ray. If the patient's unstable, you can ask for a portable chest x-ray as well. So to treat things as we see, if the SATs are less than 94%, you want a non-rebreathe mask at 15 litres. For COPD patients, you may want to give them oxygen through a Venturi mask. However, hypoxia kills before hypercapnia does. So if you're unsure if the patient's got COPD and they've got really low saturations, you can just whack them on oxygen as the first port of call if you're unsure. So if the respiratory rate is less than 12, the patient might need a bag valve mask and some ventilation. And you also may need some specific treatments at this point, so salbutamol nebulizers. If the patient is hypoxic, you can perform an ABG or a VBG, and I've got the normal values on here. For an ABG or a VBG, the lactate's really helpful, especially in surgical situations if you're concerned about a perforation. Common differentials here could be asthma, COPD, PE, a pneumothorax, pneumonia, pulmonary edema. But it's important at this point as well, and as we go making new changes, you always go back to reassess. For example, if we put on a 15-litre non-rebreathe mask at this point, we'd want to assess airway and then breathing again and then go to C. So there's a constant review of all of the changes that you've made. So the next one is C. So you want to look for any pallor, any external or concealed blood loss, any cyanosis, changes in JVP, and also changes in the hydration status. You can listen for heart sounds, and you can feel for temperature, radial and central pulses, and cap refill. The observations that you want to do here is the blood pressure, the 12-lead ECG, heart rate, and temperature. I know some people put temperatures into E, so I suppose it's just wherever it makes sense in your mind, as long as you don't forget it. Here, you want to treat the patient. If you're if you're concerned about an unwell patient, you want to put 2 wide-bore cannulae in the antecubital fossa. And these are really key words to use when you're presenting in an OSCE or an interview. You can also say which bloods that you want. So, for example, a full blood count, a clotting, cross-match, group and save would be really key things if a patient's going for surgery. You want to catheterize the patient to check their urine output. This is always something that I forget to say, so I've underlined it and put it in bold in case it's something that you guys forget as well. If the patient is hypotensive, you want to give them a bolus of fluid over less than 15 minutes, or really as fast as it will go. And if there's no improvement after a couple of boluses, you want to be contacting ITU for the consideration of inotropic support. You might have to use smaller volumes of fluid for people who are very frail and very small, or who have cardiac failure. But if the patient has these symptoms, such as shortness of breath, increased heart rate, raised JVP, you might have to decrease the fluid infusion or use inotropic support instead. If the patient's bleeding, you'd want to use the major hemorrhage protocol, and that's different for each trust. But the broad principles are that you'd have warm packed red cells, FFP, and TXA. If there is bleeding that you suspect, you want to see where this bleeding's come from. It could be coming from the thorax. At this point, it'd be helpful to do a fast scan. So it'd be a point of care scan using a bedside ultrasound. You also want to feel the abdomen to see if there's any tenderness or guarding. You want to palpate the pelvis, looking for any asymmetry. If you're concerned about any bleeding around the pelvis, you can apply a pelvic binder. And you also want to palpate any long bones and apply a traction splint if you're concerned about bleeding from this point. If you're concerned about hemorrhage, you want to do a CT trauma series for these patients. Again, I've got the differential list of what could be causing hypotension, and it's a range of things, but you're concerned about bleeds, tamponades, sepsis. I've added onto the bottom as well that if there's tachy or bradycardia, you want to follow the algorithm by the Resus Council for both of these, and I can put a link onto the comments below. So for D, disability, you want to assess the GCS, the pupils, seeing if they're equal and reactive to light. You also want to assess the glucose score and look for any focal neurology. You might want to do a CT head. There are nice guideline indications for what would qualify you for a CT head. But I've just put here, if their GCS is less than 13, or if it's less than 15 2 hours after arrival, that is an indication for a CT head. If your patient's been in hospital for a while, you also want to look to see if there's anything in their drug chart that could be causing a reduction in GCS. You also at this point want to take the glucose. So a lot of people say D also stands for don't ever forget glucose. So you want to see if maybe they've got a history of type 2 diabetes, type 1 diabetes, or if there could be something that's influencing their glucose. Also for a low GCS with a fever, always consider a CNS infection, especially if there's been any kind of intracranial trauma or any surgery involving the head and neck. And for E, we want exposure, so to examine the entire body looking for sites of trauma. Often when you're in an exam situation or an OSCE scenario, we sort of forget that we're talking about real life situations and real patients. So saying things like ensuring dignity and maintaining normothermia, so making sure that you're not exposing them in front of everyone or leaving them cold. It's really important to say these things as well. So we also want to palpate the abdomen, examine any surgical sites for infection, assess for calf tenderness, PR bleeding or rashes, and to also look for any signs of infection or anaphylaxis or any deformities which might be pre-existing or due to trauma. So with A, you want to look, listen and feel at their airway, see if you can speak to them and see if they're talking to you. If so, their airway is patent. You want to give them a 15-litre non-rebreathe mask because they're critically unwell and their saturations are low. You want to auscultate their chest. Is it clear? If so, you should be considering a PE more so than a pneumonia or a heart failure. Are there crackles? And this could be an exacerbation of heart failure. You want to take an ABG to see if there's any type 1 or type 2 respiratory failure. You'll also get an HB on your ABG to look for any signs of bleeding, and a lactate, which could indicate if there's an ischemic bowel. Glucose could also be helpful in case this is a hypoglycemic episode. You can perform a chest x-ray. Given that this patient is unwell, in a practical setting, what you'd want to do is request a chest x-ray and then call the radiographers and say that you need a portable chest x-ray and explain that the patient is very critically unwell. A chest x-ray could show any signs of pulmonary edema or a pneumoperitoneum if the patient is post-op. For C, You want to have large bore cannula for IV access for this patient. You want to perform some bloods, so in this case a full blood count, looking at their hemoglobin, their white cell count, seeing if there's any bleeding or infection. You want to look at their U's and see if they could have an AKI or a CRP. A CRP is a bit of a tricky one because it's going to be high post-operatively anyway, but you could assess their trend. A troponin to see if there's an MI. A D-dimer is not useful, it's high post-operatively, and it could really lead you down a rabbit hole. And you want to take some cultures. You want to do an ECG and also catheterize the patient for fluid balance. You want to do a fluid challenge of the patient, so giving them some Hartmann's or some saline over 15 minutes. And also as part of C, you want to look at any drains, the abdomen. You want to consider if there's any bleeding coming from any of those. And if you look over the operative notes, they should have the amount that was in those drains once the person left theatres as well. You want to consider a CT abdo-pelvis when the patient's stable if you're concerned about a leak or any bleeding. However, if the patient's very unstable, they might need to go back to theatre and you can't put them through a CT scanner. You want to consider AF rate control in this patient also. So if the patient's heart rate is running very high and they're not responding to fluids, you want to slow down their heart rate to improve their cardiac output. A beta blocker could be an option, but that would drop their blood pressure further. So in these patients, digoxin may be better. If the patient is unstable, you want to consider cardioversion with anaesthetic or ITU support. So now that you've performed your A to E and assessed this unwell patient, what comes next? You've got this unwell patient in front of you and you've stabilised them, but what do you do from then onwards? The next few slides are again from the very first session that we did, and they'll go over the management, the further questions, and what you should do in those moments after the A to E. I find this really helpful because sometimes we have in our head, A to E, and then what happens after that? What are the next steps? So the following slides will take you through that. After this, we want to go to our next part of our CRISP protocol and perform a full patient assessment. So if the patient remains stable, we want to perform a focused history, review the fluid chart, the drug chart and operative notes, review their news chart. That's really important to see what they've been trending. Like, have they just gone from a news of 0 to a news of 10, or are they sort of grumbling along at a 4, 5, 6, and they've actually been getting progressively worse throughout the day? And you want to review any available imaging and blood results. So next with investigations, when listing which investigations you want to do, the structure is really important. So you want to categorise investigations from the most simple bedside test to the more complex tests. So for example, you start with your bedside test, that's your blood pressure, ECG, and then your haematological tests. So a lot of what you want, you would have already said in the C portion of your A to E, but for example, you could say lactate. And then any radiological tests if appropriate. So for example, you might consider a CT abdo-pelvis or an abdominal x-ray, depending on what you think your patient is presenting with. So next with management, we want to consider what we think is actually going on with the patient. We want to optimise the patient. So if this patient needs to go to theatre, what do we practically need to do as a foundation doctor to ensure that this patient is able to go to theatre? So it might be considering if they're nil by mouth when they last ate. Have they had a group and save? Are you able to consent them? Could you book them into theatre or into CPOD, or contact the theatre coordinator to ensure that they have a slot in theatre? I think this is the section that I found the biggest jump going from a medical student to a foundation doctor working in general surgery, is that practically what do you need to do? You've assessed that the patient is unwell and they need to go to theatre, but then as the junior on the team, what are the next steps that you need to work on? And also to escalate. So at this point, especially if the patient's been unwell, your reg should be aware of how unwell the patient is, but maybe the reg has been in theatre all day and another registrar has been helping you. So ensure that you discuss this patient with your registrar and also the consultant responsible for the patient. You also want to discuss the patient using an MDT approach. So speak to the theatre coordinator, ICU and anaesthetics, and any nursing colleagues who have any concerns or who will be looking after the patient as well. So I'd like to thank you all so much for listening and ask if you could please fill in the feedback form. There'll be a link in the caption as well. It's really helpful for me to know how to improve my teaching and my teaching style and find out how I can make the next session as helpful for you as possible. So please fill in the feedback. Thank you.